Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome, viewers, new and repeat, to this One World, One Vision comprehensive course on strabismus, and today's lecture on Esodeviations. If you viewed other lectures in this series, I want to welcome you back. If this is your first time viewing, I'm glad you're here. We are particularly fortunate today to have as our speaker Dr. Mauro Goldschmidt from São Paulo, Brazil. Dr. Goldschmidt is the founder and director of the famous Strabos Institute in São Paulo. He did a fellowship at Smith-Kettlewell, and he has held leadership positions in many of the international strabismus organizations, including CLADE, ISA, WISPOS, and others. So it is with great pleasure that I turn the podium over to Dr. Goldschmidt.
Hello, Dr. Kushner. Thank you for the invitation to participate on this comprehensive course on strabismus. Thank you, One World and One Vision, for putting this course online. I'm happy to talk to you about esodeviations, and what I plan for this lecture is to go through definitions of esophoria, intermittent esotropia, and other types of esotropia. Those are infantile or congenital esotropia, accommodative and partially accommodative esotropia, microtropia, cyclic or periodic esotropia, sagging eye syndrome, acute adult comitant esotropia. The esotropias were associated to lesions to the central nervous system, myopic acquired progressive esotropia, and esotropia related to excessive smartphone use. Starting with some definitions, esophoria is a latent deviation observed only if fusion is disrupted by occlusion. Intermittent esotropia is a manifest deviation that is present at some times, but at others, the eyes remain orthotropic. And esotropia is a permanent convergent deviation. The clinical features of intermittent esotropia, the patient presents as a recurring temporary decompensation of esophoria, and the patient's attempts to control results in varying degrees of asthenopia, which ultimately can't be sustained. The fusional divergence amplitude becomes inadequate for the amount of esophoria, and it can be associated to mild amblyopia and imperfect stereopsis. The treatment for intermittent esotropia should be directed at eliminating symptoms or realigning the crossed eyes, expanding fusional divergence by orthoptics, to prescribe prisms to decrease the demand for fusional divergence, but surgery is what is effective by recessing both medial rectus. Let us move to congenital or infantile esotropia. I brought those two papers where they studied many neonates and they didn't find any esotropia among these children. So we do prefer the term infantile esotropia, but they be mixed during this presentation. Infantile esotropia arises between the 2nd and the 4th month of life, starting with an intermittent esotropia until it becomes constant. The clinical pictures consists on an early onset esotropia with cross fixation, a large angle esotropia, and this anomalous head position. There is a limitation of abduction, latent nystagmus and nystagmus in abduction, DVD, oblique muscles overaction, as we can see here, the inferior obliques. And there are some other clinical features, moderate or mild amblyopia, insignificant hyperopia, low familial incidence, and some characteristic electrooculographic recordings, as well as asymmetry in visually evoked potentials and optokinetics nystagmus recordings. There are some risk factors for infantile esotropia, and we can list here prematurity, intraventricular hemorrhage, cerebral palsy, hydrocephaly, seizures, and delay on neuropsychomotor development. Among the possible differential diagnoses, we can list some that has limitation of abduction, such as the Duane syndrome, but we can see the typical features of the Duane eyes, the Möbius sequence, where there is a limitation of abduction. But one of the most frequent differential diagnoses that bring the children to the office is the pseudo-strabismus with the child presenting with epicanthus. Although rare, congenital sixth nerve palsy, it is one of the possible differential diagnoses. There was a discussion about the best time for surgical alignment, some papers discussing that we should operate before 6 months of age, others between 6 and 12 months of age, but in two different Cochrane reviews in 2006 and 2013, the reviewers' conclusions was that it hasn't been possible through this review to resolve controversy regarding type of surgery, non-surgical intervention, but mainly the age of intervention. Although they published this review, some authors says that the early strabismus repair is beneficial for cortical development in human infants. And we as clinicians should consider offering early surgery for patients with infantile esotropia at or before 10 months of age. That was published by Wong. So we are facing a child with large angle esotropia, abduction limitation, jerk and latent nystagmus, DVD, oblique muscle dysfunction. The question is, what should we expect as a result for binocular vision and stereopsis? This is a publication by Dr. Julio Prieto Diaz more than 30 years ago, where he studied 123 aligned patients that had congenital esotropia surgery, and he performed Titmus and Bagolini tests. And we see here the ages where the tests were performed, and we see that the best results were in children operated before 1.5 years of age. Dr. Ng says that the optimum result in the surgical treatment of congenital esotropia generally shows binocularity that is within the confines of a monofixation syndrome, and refined stereoacuity remains an elusive target and a rare outcome, no matter at what age the alignment is achieved. This is a study did in 2002, and we can see the graphic in bars that the children operated between 0 and 6 months of age and 7 and 12. There was no difference in terms of acquiring some degrees of stereopsis, but that those children operated after 1 year of age, the stereopsis reduces. Considerations for the surgical plan. The first one is the angle of deviation. We have to measure several times. We can try to measure with covert test, but usually I prefer the Grimsky test in order to check the angle of deviation. Before surgery, we have to work hard for those children not to have amblyopia and try to patch to eliminate any ocular preference, and our goal is to have an alternating deviation before surgery. Refraction under cycloplegia and this group of patients shows a low hyperopia, although we can find some patients with high hyperopia that should be prescribed mostly for the development of visual acuity. We have to check for oblique overaction, mainly inferior oblique, that is more frequent. And if it's present, we should operate on the same time of the horizontal deviation. In this patient, we see inferior oblique overaction and V pattern. And this patient, we see bilaterally superior oblique overaction and an A pattern. Also, they might present DVD, and we can see it by the tilt of the head and fundus extortion. And how important is the fundus extortion? Well, this paper asked the question that if we can preoperatively have the fundus extortion in infantile esotropia, predicting the development of postoperative inferior oblique overaction and DVD. And we see on the results that the patients that had the extorsion showed more inferior oblique overaction and DVD. In this other paper, where they studied 105 congenital esotropias that were operated before 2 years of age with medial rectus recession, they found over 90% of the patients presenting DVD 6 years after surgery. There was no difference between those who had surgery before 6 months of after 6 months of age. And so they concluded that the presence of DVD has no relation to the age at the time of surgery. Patients with neuropsychomotor delay should be operated, but we have to plan for an undercorrection, not to let them go to a consecutive exotropia. How important is to operate on those children? We know that we have improvement in motor development, in global development of these children after alignment of the eyes. There are some infantile esotropia that comes in the presence of organic diseases such as congenital cataract, congenital glaucoma, or microphthalmos. We have to explain to the parents that in order to correct the head tilt and the deviation, we would have to operate on the sound eye. Is it possible to have a spontaneous resolution in infantile esotropia? Well, here is a case that we followed, and this is the second one that recovered from esotropia in some years. The PD group did this study 20 years ago, and they concluded that esotropia that are less than 40 prism diopters in primary position that are intermittent or with variable angle, examined before 5 months of age, has some chances for spontaneous resolution. But those where the deviation is greater than 40, constant, and they are examined before 2.5 months, the chances for spontaneous resolution decreases. Stability of measurements. We know that we might find some difference in measurements in those children. And for me, I need a reliable exam to indicate surgery. And usually this happens between 8 and 12 months of age. This other study by the PD group, they found that almost 50% of the congenital esotropias present some instability of deviation. In terms of treatment, it is surgical, and surgery for infantile esotropia consists of bilateral medial rectus recession. And to achieve orthotropia or microtropia, my experience, and that I call in my hands, medial rectus recession of 6 millimeters in both eyes corrects up to 40 prism diopters and 6.5 up to 45. And I learned not to perform medial rectus recessions greater than 6.5 because 7 millimeters might bring us a consecutive exotropia. But this is not a rule. This is a courtesy from my friend from Argentina, Fernando Preto Diaz, a patient who had 9 millimeters medial rectus recession, and here she is in her 15 years post-operative exam showing a microtropia. Deviations over 45, I do 3 to 4 horizontal muscles, and we see this young boy that I operated by age 8 months, and I perform bilateral 6 millimeters medial rectus recession and bilateral 6 millimeters lateral rectus recession in order to achieve this alignment. As I said before, any inferior oblique or superior oblique overaction should be treated at the same operation. So the goals of treatment for infantile esotropia is alignment of the eyes to eliminate the head turn and try to get some binocular vision function, fusion, and stereopsis. We know there is a variability in the response to bilateral rectus recession, medial rectus recessions in infantile esotropia. And this paper concluded that there is a high variability in surgical dose response. Can we promise results to the family? Well, at least we can try to bring the eyes to a good alignment in primary position, but our major enemy is called time, where we can face oblique overactions, and we need a second surgery. Dr. Kushner published this paper where he asked is the alignment within 8 prism diopters of orthotropia a successful outcome for infantile esotropia surgery. So on the left, we see the alignment 6 months after surgery on the group that were in small angle esotropia, orthotropia, or small angle exotropia. What we can see here is that after 5 years, the group that had small angle esotropia and orthotropia at 6 months almost remained with a good result, but not those with small angle exotropia. This is a paper by Dr. Ciencia from Argentina, where he studied the results of congenital esotropia, 390 patients operated. And we find here that 90% of the cases were aligned orthotropic and immediately after surgery. After 4 years, they ended only with 64% that remained with this good alignment. Those who had small angle esotropia immediately after surgery, after 4 years, they have continues presenting some esotropia. And a few numbers who were exotropic at the beginning, this number increased to 8%. Is there a role for botulinum toxin in patients with infantile esotropia? Yes, sure. This is one of the papers that shows a good result in 107 patients who got botulinum toxin. The question here is the number of injections that varied from 1 to 5. On the mean number of injections was 1.6. The success was 68%, but the side effects were blepharoptosis and vertical deviations. What is the most important care during the postoperative period? When we have a child with infantile esotropia that has the eye aligned, we have to keep checking visual acuity. Surgery is just part of the treatment, not the end. In a small series that we follow 19 patients, we found that 15% presented amblyopia that had to be treated. Now we are moving to accommodative esotropia. We all know that esotropia is one of the most related with sensorial abnormalities such as abnormal retinal correspondence, amblyopia, eccentric fixation, and oblique muscles dysfunction. And when dealing with a child with a normal binocular vision and an acquired esotropia, such accommodative esotropia, aligning the eye should be performed as soon as possible. Our goal in treating acquired strabismus in a child with normal eyes with onset on a developing period of vision should be to perfectly align their eyes in orthotropia with bifoveal fusion. They might present as a high accommodative convergence per unit of accommodation. It means a high ACA ratio, or a refractive accommodative esotropia where we have hyperopia above average. It's onset with an intermittent esotropia between ages 1 and 3, elicited when accommodative innervation is stimulated in a neurological normal child. And attention to the presence of amblyopia should be done especially if hyperopic anisometropia is present. ACA measurements can be done by the gradient or heterophoria methods. The most important thing in the exam of an accommodative esotropia is the refraction under cycloplegia. And measurements of strabismus angle and near fixation should be done with the control of accommodation during the exam. We can estimate how much the eyes converge per unit of accommodation, the ACA ratio. And when there is a normal binocular vision, it helps if we estimate the fusional divergences. Dr. Kushner says that if there is a mantra that needs constant repetition in imagining esotropia is refract often. And in esotropia, at any age, refraction means cycloplegic, refraction with cyclopentalate 1% twice, and refract at least 40 minutes after the instillation. If refraction oscillates during retinoscopy, wait longer for the exam. Remember that tropicamide has limited cycloplegic effect in an esotropic patient, but it increases cyclopentalate effect on accommodation and on pupil dilation. When we prescribe the full hyperopia, we can face a patient that becomes orthotropic for distance and near. So the treatment for this patient is glasses. They might become orthotropic for distance, but still having an esotropia for near. In these cases, I prescribe bifocal glasses. And the third case where we prescribe the full hyperopia and the patient still present esotropia for distance and near, this is a partially accommodative esotropia, and the treatment would be glasses and surgery. But after 2 months, if there is still a residual esotropia, we have to perform a new cycloplegic refraction. And if there is more plus, prescribe it. If it's still the same, we have to perform surgery. Now let's go and talk a little bit on microtropia. Microtropia is a well-defined entity characterized by small monocular esotropia that has a strong tendency to develop amblyopia. It has anomalous retinal correspondence, anomalous fusion reflexes, normal versions, and gross stereopsis. It can be either primary or secondary. Primary microtropia is a small angle ET in amblyopic patients who have no apparent strabismus. And secondary is a residual small angle ET that occurs after surgery for a larger angle deviation. The diagnosis of microtropia can be done with cover and cover test, Bagolini straight glasses, Worth dot test, and the 4-prism test described by Arvine and Jampolsky. The evolution of microtropia, the primary one can be compensated, remaining stable throughout life, or can be decompensated, becoming a larger angle esotropia. The secondary microtropia results of surgery for a larger deviation, and the risk factors for a microtropia to decompensate is hyperopia and amblyopia. Cyclic or periodic esotropia is a rare form of strabismus with no hereditary tendency. The alternate day esotropia, 2 days or more, is a repetitive cyclic intervals of straight and crossed eyes. The patient presents normal versions in either face, and measurements made with or without any hyperopic correction does not alter the periodic cycle. Children are asymptomatic in the esotropic phase, and it's not associated with any oblique muscle overaction, DVD, or nystagmus. Usually also not associated to neurological disorders. Here is a patient that I saw in 2021. In March 10, her eyes were in orthotropia. In March 11, a large angle esotropia. Here she is in the picture on the left and down. She's the first day post-op, orthotropia for distance and near, and it remained the same after 2 years. This is a paper published by Sousa Diaz, Kushner, and Carvalho, where they followed 7 patients that had bimedial rectus recession, and they concluded that this surgery provides a good outcome that is stable long-term. In 2009, Ruther and Dimmer described the sagging eye syndrome. Orbital connective tissues degenerate with aging, creating as clinical consequences a gradual onset of intermittent esotropia and diplopia only at distance that exceeds the near deviation by 10 prism diopters that gradually becomes constant. It progressively increases with age, less than 5% before 50 years of age, and over 60% on patients over 90 years of age. It's not related to myopia. They present with limitation of elevation and hypertropia in lateral version and cyclodeviation. It's characterized by bilateral blepharoptosis with a high lid creases, deepening of the sulcus, and floppy lower lids. It's associated with a degeneration and ultimate rupture of the superior rectus lateral rectus connective band, resulting in inferior displacement of the lateral rectus pulley. If the patient wears glasses, the natural choice for treatment is to add prisms on the glasses, but surgery on the eye muscle is the only definitive solution. Let's talk on acute adult comitant esotropia that has late appearance, constant presence of diplopia, and deserves a neurological investigation according to this publication by Hoyt and Good, where they ask if acute onset concomitant esotropia when it is a sign of serious neurological disease. The type 1 SWAN occurs after patching or as a result of monocular or asymmetric visual loss. It presents as eso or exotropia in adults, has an spontaneous resolution, and an excellent prognosis for binocular vision. Type 2 Franciscati has an acute appearance, intermittent at the beginning, but quickly becomes constant and comitant. The refractive error shows low hyperopia and normal ACA ratio. It occurs due to a decompensated microtropia. It's treated by surgery and has good prognosis of regaining normal binocularity. Type 3 Bielszowski is observed in low myopic patients. The pathogenesis is unknown, and diplopia is mainly at distance. The esotropia at distance and orthotropia at near, that has fusion, and some patients, the near distance disparity might disappear and the esotropia becomes comitant. The treatment is surgery, uni or bilateral lateral rectus resection. And type 4, Hoyt and Williams, they presented comitant esotropia associated with central nervous system tumors. They have moderate angle esotropia, nystagmus in 50% of the cases, normal fundus, and good health. But we have to pay attention to the absence of fusion after alignment and intracranial hypertension. They say that those cases had bad prognosis for binocular vision. And what are the esotropia that are associated to lesions on central nervous system? Hydrocephalus, 2 types, the early onset of an acute large angle comitant esotropia associated to A pattern and meningomyelocele and encephalocele and other central nervous system abnormalities. And the large angle comitant esotropia that appears after sudden increase in intracranial pressure and or ventricular shunt failure. It's associated to bilateral supranuclear upgaze palsy and nystagmus in primary gaze, and realignment of the ocular axis after restoration of normal intracranial pressure. The Arnold-Chiari malformation is a hindbrain anomaly with dislocation of cerebellar tonsils into the upper cervical canal. Usually, patients remain asymptomatic until late childhood or the early adult years. The most frequent symptoms are neck pain and headache. Other neurological findings may include ataxia, dysarthria, dysphagia, and dizziness. And the ophthalmic abnormalities, we can see diplopia, oscillopsia due to secondary different forms of nystagmus, A pattern, 6-nerve palsy, skew deviation, and internuclear ophthalmoplegia. Myopic acquired progressive esotropia is a late onset of esotropia in high myopic patients, as we see in the pictures on the up and right, the patient on her document, and after years presenting large angle esotropia. It starts with intermittent diplopia that progresses to permanent, and the angle of deviation increases, as we can see in these pictures of this patient, and it can end to a strabismus fixus. It presents with hypotropia in primary gaze, limitation of abduction and elevation, and on MRI, there is a supratemporal globe dislocation outside the muscle cone and the SRLR displacement. There are several possible etiologies that started in the 90s. as lateral rectus degeneration and fibrosis, lateral rectus orbital compression, mitochondrial disease, the contact of the lateral rectus to the orbital wall and displacement, and anomaly on the path of the lateral rectus. The muscle dislocation due to sclerostaphyloma proposed by Krzyzop and the poly displacement by Diemer and were the last possible etiologies for this type of the strabismus. Although this happens in adults, this is a child that was born with very high myopia and this large angle esotropia with the same limitation of abduction and elevation. And probably this is due to the size of the globe in the orbit. The surgical treatment for this myopic acquired progressive esotropia in the 90s, when we didn't know anything about it, we did a study, my group at Santa Casa Hospital, in 24 patients where we performed R&R for this large angle esotropia, and we had 93% of undercorrection, as we can see in the photos of this patient. In 2000, Yokohama proposed the union of the superior rectus and the lateral rectus without disinserting. And this is a very nice, simple, and good procedure with high chances of success. In 2002, Yamada proposed the transposition of the temporal fibers of the superior rectus that is dislocated medially, and the superior fibers of the lateral rectus that is displaced inferiorly to a position and between the two insertions. Here we see a picture of a patient preoperatively where we can see a limitation of abduction and elevation, and we can see how it improves after surgery. After that, other techniques have been proposed, and we can find all of them in the literature. And we will finally finish this presentation with esotropia related to excessive smartphone use. It was first described in 2016 as an acquired acute comitant esotropia, intermittent at the beginning, with the symptom more frequent of diplopia, and deviation starts with esotropia at distance greater than near, due to an excessive smartphone use, more than 4 hours per day and for more than 4 months, usually associated with myopia, and neuroimage was unremarkable. But cases reported by Hoyt, Flynn, and Zweitfach of comitant esotropia presenting neurological signs after the onset of comitant esotropia, they suggest that MRI should always exclude intracranial disorders. And here we see different publications of children with acute acquired strabismus and having some neurological problems. It is a decompensation of a previous deviation, microtropia, accommodative esotropia or esophoria, or a spasms of the near reflex. Usually, stopping the cell phone use has little effect on the condition. Its treatment depends on etiology, but we can try botulinum toxin in the medial rectus, one eye, both eyes. Surgery, medial rectus recession or lateral rectus resection have similar outcome. And the compensation of previous deviation, we can try occlusion, prisms, and orthoptic exercises. If there is a spasm of the near reflex, we can use cycloplegic and positive lenses. There are some potential mechanisms, and we see that there is an individual predisposition. And among the predisposing factors, we see that the excessive use of electronic devices is one of the top, together with fusion disruption. And we see on the graphic there are changes in the foria during a continuous 4 hours computer gaming session. So in summary, smartphone and tablets are not sufficient to cause strabismus. There mustn't be present an individual predisposition. There are variable etiologies. Scan is necessary to rule out any neurological problem. It is important to recognize if binocular vision is present, and the majority of surgical techniques bring comparable results. I thank you so much for your attention, and I thank Dr. Kushner for inviting me to participate on this comprehensive course, and thanks to One World, One Vision for sponsoring this series.
Thank you, Dr. Goldschmidt. That was thorough and clear and most informative. I do have one question, if I may, and that is related to the patient that has an esotropia with a greater deviation at near than distance. Let's take a hypothetical partly accommodative esotrope. They're greater than 10 prism diopters at distance, so you're going to, with hyperopic correction, so you're going to operate on them. And the near deviation exceeds the distance by a substantial amount. Let's say they're 15 at distance and 30 or 35 prism diopters esotropic at near. How do you plan your surgery? Do you target the distance angle? Do you target the near angle? Do you augment in some other way? What's your approach to that situation?
Well, this is a very interesting and important question. I approach those patients performing a small recession of the medius, and I add a Faden procedure in both medials.
And in follow-up, and I know that's a very widely used and popular technique, do you treat it differently if the convergence excess is due to accommodation, a high ACA? In other words, do plus lenses significantly decrease it, yet not to normal, as opposed to the non-accommodative convergence excess? Are they managed the same in your hands or differently?
I'm not sure I would do something different than what I said, performing the medial recession and the Faden. They have been working fine in both situations for me.
Very good. Thank you. And with that, I again want to thank you for a great lecture, and I want to thank the viewers for tuning in. If you enjoyed this lecture, which I'm sure you did, I encourage you to tune in and watch the other 16 lectures in this series. And with that, I will end the session.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the board of directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course, both visually and auditorially, extraordinary, and for their technical guidance of the lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.